All right, good morning, everyone, and welcome to this month's Georgia Healthy Farmer Mindset virtual meeting. As many of you know, each month we focus on a different topic that impacts the health and well-being of our agricultural communities. We do focus on Georgia, but this is applicable to so many of our agricultural communities. And just really appreciate this month. We're going to focus on Georgia's opioid crisis. And so we're really pleased to have Holly Lynde, who's Executive Director of the Georgia Opioid Abatement Trust under the Department of Behavioral Health and Developmental Disabilities. And then also Cammie Rice with the CWC Alliance. And with that, I'm going to turn it over to Holly, and she's going to start. She's going to tell us about some community funding resources in the next round of applications that are available to our rural communities. And so we're really pleased about that. And then we'll come back to Cammie after that. So, Holly, take it away.
Thank you, John. I'm so excited to be here, and I'm very excited to be presenting next to Cammie. So, thank you so much. I'm really excited to be here. I want to first introduce Taylor Peyton. She's going to wave. She is our opioid abatement liaison. She is half of our team. We are a team of two. We also have a couple of programmatic officers who work with us and manage all the contracts. So you're seeing almost the whole team here. Taylor, would you mind putting the website in the chat? Because just about 15 minutes ago, information on the next round of funding, the workshops for the next round of funding went up. And I mean, literally, like it was just published. So you'll be able to sign up for those workshops. So I'm going to go ahead and share my presentation. I'm going to talk today generally about the trust and the grants that we have made. And of course, at the end, I will tell you more about next month's funding or
I need
the
a
next round of
nice.
funding. Hmm? Okay. So I'm the executive director of the trust, and as such, I manage the day-to-day operations of the trust, making sure we live up to the settlement agreements with the court and running these annual grant application processes. But one thing before I want to start out is that I want to make clear that while it's sort of, if you will, we are sort of under DBHDD, we are actually a separate legal entity. So the trust is actually a charitable trust that was set up as a result of the settlement to hold the state opioid funds, basically any funds that are coming to the state. And so we are administratively attached to DBHDD with an MOU or an MOA, Memorandum of Agreement. So I am technically employed by DBHDD, but everything I do is for the trust and paid by the trust, as is Taylor. We also do have some DBHDD employees who are partially paid by the trust. Like, for instance, our communications folks help me out and they're partially paid by the trust. But most importantly, though, your grant, if you are awarded a grant, it is not coming from DBHDD. It is coming from the trust. So if you look up DBHDD policies, procedures, all that things, it does not apply. So it is coming from the trust. It is not coming from DBHDD. So groundwork laid. So the current funding that we are giving out is via the Manufacturers and Distributors Memorandum of Understanding, a settlement with the court. It is with three of the largest opioid distributors or distributors of pharmaceuticals: McKesson Corporation, Cencora, formerly AmerisourceBergen, and Cardinal Health. Formerly, it was with AmerisourceBergen, and then they either merged or bought out. I don't even know. And then manufacturers are Johnson. So ultimately, the parent company is Johnson and Johnson. So sometimes it's referred to as J&J, but really it's with Janssen Pharmaceuticals and a couple of Janssen companies that just with the parent company J&J. They will be paying $91 million to Georgia over 9 years, and the distributors will be paying $388 million over 18 years. That sounds like a lot of money, and it is. It's about $638 million. But that money is coming in over 9 to 18 years, and it's broken down in many different ways, which I'm going to go over. So, first of all, of that $638 million, the first 25% go to participating local governments. So these are cities, counties, school districts, sheriff's offices, school and hospital authorities that have signed on to this litigation. So they receive, and there's about 250 of them. So they receive their funding directly from the national administrator, Brown Greer. That money does not come through the trust. It goes directly from, it's like Monopoly. It does not pass go. It does not collect $200. It goes straight to the governments. We actually don't even know how much they get, but we have to report it. The next 75%, so once that 25%, the next 75% then comes to the trust. That's going to be give or take $479 million over 9 to 18 years. That then, again, per the settlement, is broken down additionally. That is broken down, at least 40% has to go to regional projects. And I'll talk about that. Well, actually, I'll talk about that. Taylor will talk about that a little bit as well. At least 40% has to go to regional projects. So those are, I'll talk about that in a minute. And then 60% or less goes to statewide projects. So projects that cover the entire state. So it's, yeah, $638 million, but it's broken down quite a bit. So I think a lot of you are of the age where you probably remember the tobacco settlements of the 1990s. No strings were attached. And we all know where that money went or didn't go, not to tobacco cessation. We are actually bound. There are strings attached to our money. So our money cannot go to anything other than opioid abatement, opioid prevention, treatment, recovery, harm reduction, research has to go to prevent opioid overdose deaths and opioid addiction. So what are the core strategies? This is naloxone, handing out, buying and purchasing and distributing naloxone. We're funding a lot of medication-assisted treatment. We're funding treatment for pregnant and postpartum women, expanding treatment for neonatal abstinence syndrome, warm handoff, harm reduction, syringe services programs. So we can fund things too with those syringe services programs. One of the things we can fund is Hep C and HIV treatment or preventions and testing. And of course, research on everything that's happening. And this is actually outlined in, it's called an Exhibit E. And that is an attachment to each of the settlements. So it is binding to us. And also all the participating local governments, everybody has to abide by this Exhibit E. So the MOU sets up a governance structure, which of course starts with the trustee, who is Kevin Tanner, the DBHDD commissioner. So I refer to him as trustee, although really I say commissioner a lot because it's easier. The other thing that it sets up is a government participation mechanism. And this was created, the Georgia Opioid Settlement Advisory Commission was created to satisfy that requirement. There are 9 members, 4 of whom were appointed by Governor Kemp in an executive order, 3 of whom were appointed by a process, a nomination and appointment process set up by ACCG and GMA. And then that other member, David Kidd, the MOU requires at least 1 member be appointed by the Georgia Association of Community Service Boards, and that is David Kidd. Sam Hatcher, who is the governor's executive council, is the non-voting chair. It was somebody else. He left state government. And so Sam was just appointed a couple months ago. And so all of these, again, per the MOU, all of these people must have some kind of background in the subject matter: opioid use disorder, addiction treatment, public health policy, mental health treatment or policy, opioid-related law enforcement. So everybody has a background. Another of the governance mechanisms set up is the regional advisory councils. So these for administrative, so there are 11 regions. The first 6 mirror DBHDD's regions for administrative efficiency, and let me tell you, that's a lot easier. They have to have between 3 and 7 members, and the first three are dictated by the MOU. It's somebody from a county board of health, somebody from the local CSB, and a sheriff or their designee. Again, we asked ACCG and GMA to create a process to nominate and appoint additional board member or additional RAC members. And it was determined that each would then have a University System of Georgia member, a treatment provider, somebody with lived experience, and somebody from the local judiciary. So each of the RACs, at least 1 through 6, are made up of these same 7 members. Now, regions 7 through 11 are what are called qualifying block grantees. So these are the largest counties in the state, any county with 400,000 people or more. So, of course, Cobb, Gwinnett, DeKalb, Fulton, and it's also the city of Atlanta. These are called qualifying block grantees because they receive their funding directly from us, but we do not have any impact on how they make their decisions. They make their decisions entirely independent of the trust. Whereas regions 1 through 6, they make their recommendations to the GOSAC for funding, and then the GOSAC, of course, makes their recommendations to the trustee. The way and I'll talk about, Taylor's going to talk in a second about the funding that the RACs receive. So this is basically sort of a visual of the governance structure. So you have an applicant who makes their grant funding application. If it is a regional application, meaning it falls within the geographic boundaries of that region, we forward it to the Regional Advisory Council for them to review, grade, and make funding recommendations. If it's a statewide application, it goes to, we have what's called an interagency working group. So this is a group of subject matter experts from a variety of agencies: DBHGD, public health, community health, juvenile justice, community supervision, who review and grade the applications for the state. Once the IWG makes their recommendations and the regional advisory councils make their recommendations, they go to the GOSAC, and the GOSAC then makes recommendations to the trustee. According to the MOU, the trustee does have final decision-making authority over any of the recommendations made by the GOSAC and the RACs. Again, but he does not have final decision-making authority over how the qualifying block grantees, or QBGs, make their recommendations. And then, of course, you have the participating local governments, and then everybody has to do reporting, which we're working on. But like I said, we're a staff of 2, so we're doing the best we can. I'm going to go ahead and turn it over to Taylor.
Hello again. So my name is Taylor Peyton. I'm the Opioid Abatement Liaison. We are now going to get into a little bit of how the funds were dispersed within this first year. So here you're going to see a table that demonstrates how much each RAC and state received from our first year of funding allocation. So we did allocate $50 million. So again, 60% of that were going to state initiatives, or 30 million, and 40% were going to regional initiatives, or 20 million. And here you will see how much each region received from that $20 million. And that percentage and amount was determined on a number of metrics, but the most prominent being the number of opioid overdose deaths within that area, as well as number of opioid milligrams prescribed. So who received the most harm from the opioid epidemic is who received the most dollars. And then you'll see below here, we have our QBGs, regions 7 through 11. They received their own allocations from the opioid trust that they were to do with. They were able to make those decisions independently, and they did not have to use our administrative processes to determine how they wanted to spend their money. So next slide. Okay, so now here you'll see the amount of applications we received within our first year of funding. So in total, we received 306 applications. Of those applications, 99 went to state, 70 to Region 1, 39 to 2, 24 to 3, 13 to 4, 33 to 5, and 28 to 6. And you'll see the corresponding dollar amounts requested from each of those regions versus the amount allocated. So those regional advisory councils really had some very hard decisions to make when it came to determining how they wanted to spend their first year of funds. And next slide, please. Now, from the 308 applications we received, these are the project categories in which we're funded. So you'll see here on the regional level, predominantly treatment and recovery was funded, prevention following. Next slide, please. And then on the state level, you'll see predominantly prevention and recovery applications were funded. This does make sense. We usually see treatment and recovery happening on a more localized level, where prevention and recovery can also happen in a statewide context. Next slide, please. So overall, we have funded 128 projects, 79 regional projects, $14 million dispersed in year one, 49 statewide projects, and $28 million dispersed in year one, for a total of $43.4 million dispersed in year one. So for our next steps for the opioid settlement, we are going to be hosting a number of opioid workshops of how to apply for the funds and what the expectations will be. Those are going to take place May 2nd, 5th, and 6th in Savannah, Tifton, Dalton, and Atlanta, and one virtual session. Again, those are posted on our website for your reference. On May 5th, the new notice of funding opportunity will be posted on the website. This will be a little bit more specific than last year, so it might help you. Monday, May 19th, the grant portal will open. This will be open for 30 calendar days and will then close on June 17th. We will begin notifying people of their awards decision in November, and then January or February of 2026, funded projects will begin work. Next slide, please. Oh, I think there was one before that.
There was just the website. The website's here too.
Okay. Yes. So the previous slide was our website. Please, it's in the chat. Please visit it. It will have last year's NOFO, a ton of resources for you, previous webinars. Please check it out. You can see applications that were funded last year to kind of give you a good sense of things you could and should apply for. A lot of resources on there. Please check it out. But on this page, you will see me and Holly's contact information, as well as the GA Opioid Trust email. It is me and Holly answering those emails. You can also submit some Zendesk tickets through our website. That will also be me answering those tickets. So please reach out to us if you have any questions, if you want to brainstorm about what you could potentially apply for. We are here and available for you to answer all of your questions concerning the opioid abatement, and please utilize those resources because we do want you to apply and we want to help Georgia and save lives. Thank you.
The one thing I will add is that your application is eligible for regional funding if it falls specifically within the geographic confines of that region. If it falls across two regions, and that includes QBGs, it is eligible for state funding. So keep that in mind.
Thank you so much, Holly, and also Taylor. I would ask if you will drop those that website and your contact information into the chat, if you don't mind, so folks can copy that if they want more information. So thank you so much for sharing that. With that, we're going to go to Cammie Rice of the CWC Alliance, who is going to be talking about a very important program, a growing program, and really an exciting program in the areas of our state to address care and prevention, trying to basically head off the opioid impact on an individual before it happens. And I just love their approach. And with that, I'm going to turn it over to Cammie. And Cammie, take it away.
Okay. Thank you, John. I really appreciate the opportunity to share our mission, and just want to thank Holly and Taylor. What an enormous job you all have had in just doing it with staff of two. God bless. So thank you for that. It was very informative. So yes, I am the founder of CWC Alliance. Anytime I'm blessed to have the opportunity to share our mission, I always start with the why, our why. And many of you are familiar with CWC Alliance and our story, but I always start with my son's beautiful smile, because Christopher had a health crisis in high school. He was diagnosed with ulcerative colitis. He had to have a surgery. It was exactly the timing of when Purdue Pharma released OxyContin as a wonder drug. And we went home with 90, followed by 90 more, and it completely hijacked his brain. But let me tell you a little bit about Christopher. He had aspirations to be a Navy SEAL. And a lot of times we all hear these enormous numbers of deaths, but we have to keep the individual faces that these are actually families that are being devastated. And how many people are affected when one person dies? I can tell you his sibling, cousins, aunts, uncles, grandparents, and of course, parents. There's nothing worse than losing your child and feeling like we did everything in the world to help him. Literally, the opioids hijacked his brain during that health crisis, and he fought it for 14 plus years and then lost his battle February 26, 2016. So that is our why. Many of you are aware on this call of the problem that our country faces, that over 16 million Americans misuse prescription medications. And what scares me and keeps me up at night is that people don't understand the dangers that you can become addicted with actually one prescription. And that could come from a dentist getting 35 Percocet for a wisdom tooth extraction. We really have to become health advocates and understand that there are dangers. There is a place and a time for opioids, but understanding how quickly you taper off when you have to be on one. Nearly 80% of heroin users started with an opioid prescription. And we have a fentanyl crisis, and the opioid epidemic and the fentanyl crisis are very closely related, and it is the leading cause of death, age 18 to 45. Go to the next slide, please. So, what is our solution? Here's the thing. If you look at our society, let's think about how many things we use coaches for. Every sports team, imagine the Super Bowl with no football coach, right? We use coaches for everything. There's executive coaches, workout coaches, every sports team. But when you're in the hospital, you don't have a coach at bedside to help you get through that health crisis. And so we've actually developed a new position in hospitals that is integrated with the healthcare team. Nurses are amazing. I don't know what I would have done without nurses all the time Christopher was in the hospital. But they don't have the time now. They're overloaded and they don't have that time to give that opioid safety education. If you do have to be on an opioid, to understand how quickly and important it is that you taper off and that you don't look at that as a long-term solution for pain, and someone to help you at bedside to manage your pain. We have a toolbox with all these new innovative solutions to do brain distraction when you are in pain. And then there's the mental side of being sick. When you're in the hospital, you have anxiety, stress, depression, PTSD, probably all four of those things because you're in the hospital. We probably have those issues right now. We're not in the hospital, right? Just with everything going on in our world. So we have trained in Trauma Resource Institute, and we have coping techniques that we help at bedside to help with the mental side of getting well. And what happens is when we spend this time, many times patients need a listening ear. They need someone to validate their pain, someone to listen to what's going on in their life. And so what happens is we uncover all these other comorbidities, maybe food insecurity, home insecurity, domestic violence, and we're able to get them resources where historically, those patients would have fallen through the gap and nobody would have known about those other issues that were going on in their life. So again, it's to be that care coach. We do, as I said, innovative things to help distract pain that have nothing to do with a pill. Unfortunately, our culture and our society, we've been trained to think ill, pill. We have a headache, we immediately go for a pill. Instead of taking a big drink of water and going outside and letting the sun hit our face, we are trained to think ill pill. So we really try to help with innovative ways that are non-addictive to deal with your pain management while you're in that hospital crisis. Next slide. So this role is called a life care specialist. And, we'll talk a little bit about where we are in Georgia today, but we're also community advocacy. There's a lot of stigma that goes around with addiction. And so we go to the Rotaries, we go to schools, we train about naloxone, we train our mental health skills. We really try to break the stigma that we need to be having these conversations at kitchen tables, to be talking about the fentanyl crisis, warning young people about what's going on with street drugs, et cetera. So the life care specialists not only work in the hospital, but they're very integrated with what's going on in the community for advocacy work. So we train, we have a robust training curriculum. It's housed at Mercer School of Medicine. There's 13 modules that are taught by the Mercer faculty at the medical school and CWC as well. There is a quiz after each module. You get the certification, and then there's the practicum piece. Currently, Grady is our training hub, and we do the practicum job shadow piece where you actually are on the floor training with a life care specialist. Then you become certified as a life care specialist. Listen, who I was before Christopher passed away, I worked in the software industry, and my job was to manage partners. I managed IBM, Deloitte, Ernst & Young, Accenture, and I had no idea at the time that was training me for what I'm doing today, because the key to this war on the opioid epidemic is partnering. And we've got to work as a state. We can't work in silos. We would not be even close to where we are today, CWC, if it weren't for our strong, strong partners. To have the relationships that we have with Mercer and the Rural Innovation of Health, Grady, Emory. I'm not going to list all of our partners here, but I am so grateful for our partnerships, because that's allowed us to get to where we are today and our success with the program. Next slide. So where we are today, super thankful to the state. We were not primary on the last round we were partnered with Grady. Grady is the one that applied, and I'm so thankful that the state recognizes existing programs. So we had our life care specialist program at Grady funded for the next 2 years. Bless, bless. This is just amazing, because we're able to keep our program going at Grady, which is doing very well. We're in orthopedic trauma. We're in sickle cell unit. We're seeing so many patients at Grady. So incredibly grateful for that. We also received opioid abatement settlement money in the state of Arkansas. Arkansas is the #1 prescriber in the country. Their goal is to have life care specialists in every hospital in the state of Arkansas. I was privileged to get to speak at the Georgia House. I believe Taylor, you were on that committee, to get to speak. And they came back with recommendation to the state that life care specialists should be in every single hospital. And our North Star is that they are in every hospital in Georgia and in the United States, and it is doable. We are also Harvard Business School. They said, wow, let's do a case study on this. This is a new position in hospitals. It's workforce development as well. We're putting people to work in rural and urban communities. And because we had so much success in such a small time, they have decided to follow us on our entire journey at CWC. Next slide. We also partnered with Resilient Georgia, and we applied for a statewide teen opioid fentanyl prevention education and training initiative. This will be peer-to-peer. The beauty of this is we can't be telling young people, they're not going to listen, but they will listen to their peers. So we're going to train and activate young people and actually pay them as a job, which is also workforce development, right? And train young people to train other young people. That peer-to-peer model is evidence-based and works. So we're super excited to roll out statewide our youth program that we'll be doing again with Resilient Georgia. And then I'll just mention, I wrote a book, and it just released in audio. I recorded it myself as the author. And the reason I say this is because, look, I cannot get my son back. I am trying to save other young people, other family members from going through pain of loss. And this book is allowing me to get to the masses. I share my story, but it really makes you reflect on your own. And there's a QR code in the back that we constantly update with resources, new partners that join our crusade. So I please invite you. All the proceeds go to our charity to provide patient care packages to patients in hospitals, et cetera. So that is us in a nutshell. We're really, really thankful for having this opportunity to share our mission. We're thankful to the state of Georgia for supporting us. And I don't know if you want to open up to any questions or if you have time, but I'm thankful for the opportunity. So thank you very much.
Yes, we do want to open up for questions for both of sets of our presenters. Cammie, Tara Haskins from AgriSave did ask a couple of questions in the chat, so I'd like to ask Tara could just go ahead and ask those questions to you now.
Oh, great, great. First, Cammie, so impressed with the creation of this very special role. And you are right, I'm a nurse. I worked in addiction treatment. When you work in addiction treatment, you have the time, but when you work in the hospital, you don't have the time. So what departments in hospitals do life care specialists work under? And other than that wonderful training that you shared, what are the other qualifications for a life care specialist?
Great question.
And are you doing this in VAs?
We want to move into VA. That is actually absolutely on our list. And I did want to mention the rural hospitals that we're in Georgia right now are Coffee, South Regional. We're actually hiring. So if anybody is in the Valdosta area, we are currently hiring for a life care specialist at South Regional. We're in Coffee Hospital, Stevens Hospital, and Mountain Lake Hospital. In the rural hospitals, we're able to see the volume of all patients. We float. We are in the emergency department. We're dealing with maternal care. It depends on the volume of the hospital and whether we have one life care specialist there or two. We're going to be applying for more funding. So when we do a hospital assessment and we look at the volume, but we started at the urban hospitals at Grady, we started in orthopedic trauma because that's the first place that young people are introduced with opioids, with a sports injury or a car accident or whatever. So we started in orthopedics and we definitely have a strong suit there, but we're able to really see all patients. Who doesn't need a care coach when they're in the hospital, right? And it's really our swim lane is prevention. When we do a risk assessment. If we see there's a substance misuse, we're partnered with a Georgia Recovery. We have peers in recovery that we can connect a patient to, and our life care specialists have gotten many patients into treatment. So we really look at that as saving one life at a time. Great question. Oh, did you ask the qualifications? So it is very, very helpful if you have a healthcare background. In the rural communities, we do not require a 4-year degree because we're looking for what you've been born with, which is compassion and empathy and a listening ear. We can train you. You do have to pass the modules. You do have to pass the certification. But if you've got the right heart for this, we can train you. Now, we've had social workers apply, MS workers apply. We do have people with masters and people that have been social workers. It's really a variety of people, but we do hire in the rural community. It needs to be that trusted individual that lives in that rural community to work at our rural hospitals.
Thank you.
Cammie, I have to say that I was actually thinking of you yesterday because my numbskull child went rock climbing at a local gym without a harness and fell and shattered her ankle. So originally we didn't think she was going to need surgery. She now needs surgery, and it's going to be at an outpatient facility at Emory, the Emory Orthopedic and Spine Hospital. And of course I was thinking, I wonder if they have the life care specialists at outpatient facilities like that. And I just got a notification about the prescription that they sent in for her. They did not prescribe an opioid, only naproxen. I thought that's really interesting. So she's 18. So, and we, of course, even if we had we've got opioids floating around. We've got opioids in our safe at home, but, and I have addiction that runs in my family. But I just thought it was really interesting that they, at least what I looked at, they did not prescribe her any opioids.
That's really wonderful to hear.
Yeah.
We recently did, we were featured in an article with WebMD where we did a case study that we had a 20-year-old here in the state of Georgia, got hit by a truck on a moped, and he was
Ooh.
prescribed, his mom had over 100 Oxycontins at their house. And I literally physically got in my car, we weren't even at that hospital, but a doctor knew of our program and called us. There's just so much more overprescribing that's still going on nationwide. It's not just Georgia. There's a lot of overprescribing going on. And this 20-year-old, it was like looking at my son all over again, a 20-year-old being prescribed over 100 Oxycontins, which is really negligence and criminal, to be honest, in my opinion.
Who prescribes 100 pills of anything?
Right, right. So we have to become health advocates, and we have to ask questions, and really be our own health advocates, because there is a lot of overprescribing still going on in the state, even though there is a database, there is red flagging with physicians, and it's getting better, but it's still not where it needs to be. Any other questions? These are all great questions. We're super excited to expand. And thank you, John. Sorry.
No, Cammie, would you mind just telling the group a little bit more about the CRIM training? And I know that's
Yes.
that's been an important tool for you and a number of folks. I see John Anderson from the Rural Health Innovation Center at Mercer, and John's trained in that. I'm provisionally trained. Would you tell the group a little bit more about CRIM training?
Yes, yes. They're a huge, big partner of ours. It's the Trauma Resource Institute. Actually, the founder is on our advisory board. It's a great story how I met her, but and I was able to introduce Mercer to him. So it's just great to see it expand. They have a model called the Community Resilience Model, and there are techniques really to control your nervous system. They're simple techniques because when you're having a panic attack, when you're having anxiety, and you're nervous, you're bumped out of your resilience zone, you need easy skills to get calm again. And so we all get bumped out of our resilience zone. We either get bumped out and we're angry and we're mad, or we go down and we're sad and we're in fetal position and crying or depressed and in a funk. And so the point is not to get stuck in either one of those places. And so we have these coping skills to bring you back into that resilient zone, and they actually work. I use them on a daily basis. I mean, and we've trained over 600 frontliners at Grady and Emory. Carter did an amazing job running that team, because if you look at during COVID, what kind of stress our frontliners had to deal with patients dying, and so that we were able to train the nurses on the community resilience model. Highly recommend this model. And you don't have to become an instructor. I know, Joan, you're an instructor, but once you you can also be a guide. And that's what we're going to implement with our youth program across the state, is educating young people, because we know the suicide rate is so high with young people. You've got to have coping skills to deal with today's world, right? I mean, we all need that. So I highly recommend the community resilience model. And I will say they have a app that is free. And Carter will put that in the chat. It's called iChill. You can download it for free. It has the entire model on it. It goes through all the grounding exercises, the resources, and she's got such a calming voice. It's so relaxing. I highly recommend you checking it out. It's a great introduction to the model if you download iChill. And you might want that, Holly, for your daughter when she's going through her stuff, and we will be happy to send you some skills that our life care specialists can share for your daughter to have.
Great, thank you so much. And I know Glenda Grant and the team at the Rural Health Innovation Center. We certainly appreciate you connecting us with that, because it's been something that they've definitely taken the ball and run with in the state. So, any other questions before we kind of go to the part where we share a little bit? And I'm going to give a few shout outs about some things that have happened with the Alliance recently. And so, any other questions for our presenters today? Okay, well, hearing none, again, we've got all their contact information, and the websites are in the chat, and that's just wonderful. And we're gonna, and again, we'll be sharing this. I do want to say, first of all, next month it's Military Appreciation Month, so we're going to be focusing on veterans in Georgia agriculture. And we're excited about that. So more details on that later. And I'd ask if you could, and then again, we focus on a different topic that impacts our ag and rural communities each month, and so we try to provide different information about those impacts and also resources to support those populations. And I just ask if you would. To spread the word about this monthly meeting. We do keep it to an hour. We are try to be very respectful of everybody's time. Lily Baucom just did a great reminder that it is also Mental Health Awareness Month next month. I was focused on our topic, but yeah, that's a great point, Lily. And then Julie Glenn from GRIC just said that the CWC Opioid Conference at Mercer on September 18th. So put that on your calendars as well. And so, Tara, I think you, if do I remember correctly that you were going to share a little bit about some of your work in with the opioid thing, or am I misremembering that?
I didn't recall, but I can share what AgriSafe has in terms of opioid work, and I've been trying to connect to people on the chat here because this is really exciting. This is an amazing meeting. AgriSafe since 2019 has had a group of modules that focus on the agricultural workforce and opioids. And those were done in conjunction with some funding that we received out of Mississippi State University. And those are really focused on the risk factors that exist in agriculture. And it also, it also addresses talking to farmers about their pain, which is really important because we do know that agriculture has a high rate of significant injury. And so we know that opioids are out there. It also talks about safety sensitivity in terms of opioid use in the workplace. Most farmers and ranchers, they're small businesses. They don't have HRs that manage that sort of thing. And so we felt it was important to have that information. Those modules are grouped together and really for healthcare professionals so that they can have better conversations if they have someone that works in agriculture in front of them about those specific issues. And we are getting ready. We want to re-update those trainings and certainly get some continuing ed that's going to be associated with those. And AgriSafe also we do naloxone trainings. We try to tailor it to the agricultural workforce. And because when I stated earlier that most ag producers are heads of their small business, so they don't have HR, we try to provide them with some tools that if they decide, and we encourage them to keep naloxone at the workplace, whether it's in the barn, whether it's on a pickup truck, because they do hire, they are an employer, and how they can feel comfortable about having naloxone at the workplace. Of course, the challenge when you have naloxone at a workplace that's an ag, that's a production, you've got large expanses of land to cover, and where do you keep it, and how do you keep it so that it doesn't lose its effectiveness in those extreme temperatures? We try to have those conversations and give them suggestions and ideas. So in a nutshell, it's 4 modules, and we are looking to update that. And I will certainly be reaching out to these amazing speakers that you brought here today, John. And I'll put my email in the chat for the group if they want to get a link to get an idea of what those modules look like.
Thank you, Tara. AgriSafe does a great job with providing different resources to support our agricultural communities, their safety and well-being, and we really appreciate that. Jeff Breedlove from the Georgia Council for Recovery posted a reminder about the 2025 Georgia Mental Health Month Summit. Jeff, do you want to say a little bit about that?
Oh, John, thanks. Thank you, sir. Commissioner Tanner will keynote an event at Urgent Psych. Urgent Psych is located basically at Spaghetti Junction in Atlanta, to give you all a point of reference. And it'll be a half-a-day conference with a panel of advocates and a number of the co-chairs of the General Assembly Mental Health Caucus will be speaking, 3 of them, and some other movement leaders. So it's free to attend, and there is about 200 seats available. So on the one hand, we don't expect there to be a problem, but if you do want to sign up, we encourage you to do so. Thanks for that. And the second thing I put in there was a virtual announcement that Commissioner Tanner is making on the 15th about the bus tour. And there'll be 74 stops, and a very large number of those stops will be throughout rural Georgia. And it'll be coming to a city near you. And we really want to reach out to folks in agriculture, agribusiness, and any stakeholders in rural Georgia, and let you know that you're very welcome to reach out to me and say, look, we've got a speaker we think would be great for one of the stops. We're very, very open, and we want to be very inclusive. So if you've got an idea for somebody you think should speak, we're certainly open to your concepts.
Great. Thank you so much, Jeff. I appreciate that. And Joan posted a reminder in the chat that the Georgia Rural Health Innovation Center sponsored conferences and CRM training, are provided at no cost to participants. So they're accessible to all who are interested and may benefit. Thank you, Joan, for that. With that, I want to give a couple of shout outs real quick, and then we'll open it up for any other events and all that you would like to share or any of your work. First of all, I want to give a shout out to our partners at the Community Service Board of Middle Georgia, Denise Forbes, and also Erica Stokes. Erica shared recently a blog that she did on Agricultural Awareness Day. It was an awesome blog that we're just providing support for our agricultural communities and the things that they wanted to help increase awareness about within that community. And I just really appreciate them. Erica, if you will post the link to that would be great, to the blog. They do a great job of that, and we love to work with them. So thank you for that. Recently presented to 2 Georgia Young Farmers and Ranchers groups in Scriven County, and most recently a couple of nights ago up in Walker County. These groups were just so engaged about this, and I know one of the things that a lot of folks have said is, farmers and farm families won't open up about these concerns that we have about different folks and our friends, our neighbors, our family members. But I've really found them to be very engaged in this topic, and that's just growing more and more. I think they recognize that mental health is health, and I just appreciate what the Georgia Young Farmers groups have done to try and, at the state level, to try and destigmatize this conversation, as many of our partners have. And I really, really appreciate that. So I wanted to give that a shout out to those. Now I'm going to open it up. We've got about 10 minutes to go. So if you have an event or some work that you have going on now and soon, please share that with us. Okay, I'm going to put Lily Baucom on the spot. Lily, do you have anything that you'd like to share from your area and from the Foundation for Ag and some of your work? I know you've got some great things going on.
Sure. So I may have mentioned this last time, but we are working on a programming guide. We've entered into a partnership with American Farm Bureau, and they do a lot of mental health awards at the national level. So we have been able and fortunate to be able to look through all of the award applications from all counties in all 50 states. So we're trying to compile what are best practices and programs that people can do at a county level, and then kind of scale and rate those as if you don't have a lot of volunteers or if you don't have a lot of money to be able to do programming, these are still ones that can be impactful. So we're getting closer to being able to roll that out. It's going to be a tool for our county farm bureaus to get involved. And we'll have our own awards programs, but it's also something that we want to push out through the Georgia Ag Wellness Alliance, and hopefully we'll be doing it at the national level too. We had, done a lot of research, and now we're really entering into the phase of how do we help our county farm bureaus do more programming. So mainly working on that. And we also applied for an interesting grant, which we should find out about soon, potentially to do some mental health trainings with ag lenders. We recognize they're some of the first ones to, know when a farmer is in a financial crisis, and that's a top stressor for farmers. So hopefully we find out about that soon and can get to work with that. And then I did put a reminder in the chat about next month being Mental Health Month. American Farm Bureau does a really good job of creating social media toolkits and resources for us to be able to share and push out. So that's something we're trying to kind of standardize across all of the farm bureaus across the country to be able to get resources to folks who need it. So those are my main.
Thank you so much, Lily. As I, listen to all of these presentations and the conversations that I have out on the road here, I'm just so excited that this conversation is happening with so many partners in Georgia and across the nation. And if you think about probably where this conversation was, or more accurately, wasn't about 5 years ago, probably, it's really come a long way. And I've seen a difference just in the 18, 19 months or so that I've been on board with the Rural Health Innovation Center at Mercer. People are really starting to open up about this within the agricultural community. I think it's so important that we have those conversations within, and then we help people outside of the agricultural community understand what our farmers and our farm families are up against. And I think that's a two-sided conversation that is so, so important. So thank you all for what you're doing on that. I think we have just a couple of more minutes that we could share. Anybody else that has something that they'd like to share? Cammie asked that we ask to consider following on social media the CWC Alliance. We will certainly do that, Cammie. And then Jeff Breedlove has put in his contact information for anyone interested in speaking at or recommendations for the Georgia Recovers bus tour. So anybody else want to share before we wrap up? I see so many
want
of
to
our
mention that the recovery bus, Jeff, am I allowed to say that it's going to be, I guess I can, right? So the recovery bus will be at Mercer on September 18th at our conference that CWC is partnering with Mercer School of Medicine and the Rural Innovation Center. And the recovery bus is going to be there at our conference. And you will also be able to receive continued education credits for coming to the conference. And I got to say, we've got some really amazing speakers lined up and some panel discussions. So there'll be more coming out. We'll be advertising it throughout the state, but we're super excited about the conference. And it happens to be on Christopher's heavenly birthday. So I'm excited to be able to do something that special on his birthday. So I hope y'all can come.
Yeah, thank you. Thank you so much, Cammie. Well, with that, I want to I want to wrap us up today and just thank you all for being here. The conversation here, please spread it. We really need to keep this going, and I just appreciate you all so much. The different work that you bring to these topics and support for our citizens and especially for our agriculturists. So thank you so much. Please spread the word about this meeting. We're growing bit by bit, and we want to get this word out more. So thank you, everyone. I appreciate it. We'll be posting the video of this today. We'll be posting that on our website, and we thank you so much for your time, especially our speakers, your time and efforts in your work. Thank you.
Thank
Have
you.
Have a great day and a great weekend.